Uh, so good evening, doctors. Good evening, ma'am. Shall we start, ma'am? Madam, shall we start the webinar, ma'am?
Yeah, of course, we can
Yeah.
start.
Yeah, ma'am. So very good evening, doctors. I'm Dr. Stalin on behalf of Shield Healthcare, welcoming you all for today's webinar. Topic for today is recurrent endometriomas, how to tackle. I kindly request the participants to post their queries in the comment box. At the end of the presentation, we'll be having a short Q&A session with the presenter. And now it's time to introduce our eminent speaker for this evening, Dr. Yadini Selvaraj. Thank you, ma'am. Thank you for accepting our invitation, and it's a honor to introduce you, ma'am. So, madam was a former assistant professor of Ops and Gynecology Department, Madurai Medical College, Madurai, and currently, madam is the managing director of Madurai Ponni Fertility and Research Center. And she is also the chief consultant gynecologist, IVF specialist in Madurai. And madam has more than 15 years of experience in fertility treatment, and madam is a member of various societies like IFS, ISAR, MOGS, Indian Menopause Society, PCOS Society, Foxy, ISHRI. And madam is also a editorial board member of International Journal Annals of Clinical Case Study and Reports from Texas, USA. Madam has done more than 350 presentations in both national and international conferences. Madam has received various awards like Amazing Woman Award, Woman Entrepreneur Award, and Dr. Abdul Kalam, or sorry, Dr. Bharat Ratna APJ Abdul Kalam Award for Excellence, and Mayan Awards in 2018 at Malaysia. And Madam is the best clinical, has received the best clinical paper award in the Vertivision 2019. And madam has done many certifications of achievements awards, World Congress on Human Placenta, Fetal Nutrition and Metabolism in Las Vegas, USA. So with this introduction, ma'am, I welcome you for our presentation today. And madam, you can start your presentation, ma'am.
Thank you so much for your kind words. I bring greetings from Pune Hospital. And at the outset, I would like to thank the organizers and the Shield Pharma for giving me this opportunity to deliver my speech on recurrent endometriomas. It's a very great problem, and I'm going to talk on a simplified manner in which I'm going to tackle this recurrent endometriomas. We all know that endometriosis is an estrogen dependent disease, frequently resulting in substantial morbidity, severe pelvic pain affecting the reproductive health, and it requires multiple surgeries and with impaired fertility. Clinically, it is defined as presence of ectopic endometrium resulting in sustained inflammatory reaction. It is found predominantly in women of reproductive age, and the exact prevalence is not much known. It had been estimated that 176 million women are worldwide are suffering, but now it had gone up to 200 millions, and around 29 million women in India suffer from endometriosis. Among them, 50% are infertile, and lots of immunological factors are significantly incorporated in the pathogenesis of endometriosis. There is cytokine dysregulation. The endometrial cells are able to exploit the promotion of vasculogenesis and angiogenesis mediated by inflammatory response. And there is still debate going on whether to classify endometriosis as an autoimmune disorder or as an inflammatory disorder. This picture depicts how it is estrogen dependent, how retrograde menstruation can cause endometriosis, angiogenesis, local inflammation, oxidative stress, and the stem cells, which can mutate to endometrium. And this is the revised ASRM classification of endometriosis, which takes into account whether it is superficial or deep, the size of the endometriomas or the endometriosis lesion, and they grade accordingly. From 1 to 5, it is stage 1, and from 6 to 15, it is stage 2, 16 to 40 is stage 3, and above 40 is severe endometrioma where the pelvis may be almost frozen, and the deep infiltrating endometriosis also comes under this category. How to diagnose it? There are several causes which delay the diagnosis of endometriosis, and ultrasound plays a major role in diagnosis. In current clinical practice, laparoscopy is required for definitive diagnosis of early endometriosis. Many risk factors are associated with endometriosis: infertility, early age of menarche, shorter menstrual cycle, heavy menstrual bleeding, nulliparity, Mullerian anomalies, exposure to diethylstilbestrol in utero, dioxin exposure, endometriosis present in first degree relatives, and history of prior or medical therapy for endometriosis. The clinical features, it may be either asymptomatic or may be associated with pelvic pain and or infertility. The pain related to endometriosis may present as any of the following, like dysmenorrhea, dyspareunia, dysuria, dyschezia, low backache, and abdominal discomfort. There may be chronic pelvic pain, which may be acyclic abdominal pain or pelvic pain, which may last for more than 6 months. The clinical findings, we could see a fixed retroverted uterus. There may be sometimes adnexal mass appreciated, and the nodularity of uterosacrals may be present, which may be thickened or may be tender. In current clinical practice, laparoscopy is required for definitive diagnosis of endometriosis. What are the things in endometriosis causes infertility? Let us see now. There is ovulatory dysfunction, which causes abnormal folliculogenesis, anovulation, luteal phase defect, luteinization of unruptured follicle. That may be the earliest sign of endometriosis. And immunological alterations like decreased sperm survival, altered immunity, peritoneal factors, that is intraperitoneal inflammation, local production of prostaglandins and cytokines. There is interference with implantation like endometrial dysfunction. Mechanical factors also play a part. There is anatomical distortion of tubes, altered tubal motility, interference with ovum pickup. There is peritoneal adhesions also. And the coital function is disturbed because of dyspareunia. There is severe pain during coitus. And macrophages, they phagocyte the sperms and make them inactive. So that also plays and contribute to infertility in endometriosis. Now let's look into the management. The conventional method, that is expectant management or medical management and surgery. Then we have the sclerotherapy. The known sclerosing agents are ethanol, tetracycline, and methotrexate. The newest sclerosing agents are leuprolide, cefaperazone sulbactam, interferons or interleukins, recombinant interleukin 2, and metronidazole. For infertile patients, when the AMH is very low, you may go for IVF with embryo transfer or oocyte donation. Medical therapy in endometriosis is non-specific, non-curative, and aimed at alleviating symptoms till menopause or until pregnancy is desired. The medical therapies, the rationale is to induce an amenorrhea and create hypoestrogenic environment, theoretically inhibiting the growths and promoting temporary regression. The side effects may be intolerable for some, and symptoms recur upon cessation of therapy. Fertility is eliminated during treatment as medical management suppresses the ovulation. And selection of medical therapy depends upon the therapeutic effectiveness, tolerability of the patient, the drug cost, the physician's experience, and the expectant patient's compliance. The current medical therapies that are available are hormonal contraceptives, gonadotropin releasing hormones, danazol, and non-steroidal anti-inflammatory drugs. The newer hormones in the medical management are GnRH analogs like leuprolide, naferilin, goserelin, and triptorelin, and GnRH antagonists like linzogolix, elagolix, and relugolix. And these are all in phase 2 and phase 3 trial. Progestins, depomedroxyprogesterone 150 milligram or danazol 400 milligram per day orally or 1500 to 2000 milligram as intrauterine devices can be used for deep infiltrating endometriosis. And norethistyrone acetate, Dynogest, retroprogesterone like dydrogesterone, and levonorgestrel impregnated intrauterine devices, which releases 20 micrograms of levonorgestrel for 24 hours, can be kept for 5 years or so. And etonogestrel is implants that can be implanted subdermally. The aromatase inhibitors like letrozole 2.5 milligram, which can be combined with norethistyrone 5 milligram, can be given for 6 months. Anastrozole 1 milligram plus 200 milligrams of progestin for 6 months. The disadvantage of these is there is decrease in the bone mineral density and hot flushes we have to face. Then the selective estrogen receptor modulators like tamoxifen, raloxifene, and bansidofexin can be used as 10 milligram per kg dosage, and selective progesterone receptor modulators like asupressril and tilaprestone, and estrogen receptor ligands like estrogen receptor alpha and beta. These are all the newer things that comes into focus. Anti-inflammatory drugs, that is the angiogenic inhibitors, that is vascular endothelial growth factors and matrix metalloproteinases. Then the endotrophic implants grow in ectopic locations with the new blood supply. So that can be tackled with all these anti-inflammatory drugs. The TNP 470, which is derived from aspergillus, endostatins derived from collagen, and dopamine agonist, that is gabagoline, in dose of 0.5 milligram given inhibits the neuroangiogenesis. Rapamycin, doxycycline, and rosiglitazone. These are all the newer things that are being tried to tackle endometriosis. And drugs under research, the immunomodulators like loxoribin and interferon alpha 2, tumor necrotizing factor alpha inhibitors, retinoids. These are all the newer immunomodulators. And pain management can be tackled by gabapentin, amitriptyline, antioxidative drug like resveratrol, and the future direction is targeted to treat with genes and genomics. But so many things are there. Too many cooks spoil the broth. The limitations of current therapy, the major limiting factor of currently available drugs are their adverse effects and the ability of the patient to tolerate them. There is always dissatisfaction existing between patients or among patients regarding to the effectiveness of the therapy and the impact condition on their lives. Dynagest, the synthetic oral progesterone, it has an unique pharmacological property. It reported as to display no androgenic properties. It has a very good estrogenic effect on the uterus and has a favorable safety and tolerability profile. The limitations of Dynagest, pregnancy can't be achieved during Dynagest. That's the problem. And it's very expensive also for the developing and underdeveloped countries like us. It ought to be continued for a longer time, for 12 to 24 months, so people can't afford for such a costly drug. Surgical management of endometrioma. The surgical treatment is the mainstay for endometrioma, measuring more than 5 centimeters. Laparoscopic excision of the wall of the endometrioma should be considered as the procedure of choice. Concerns have been raised as to the possibility that surgical excision may damage the ovarian reserve. But recent evidences demonstrate that part of the damage may be due to the disease itself. The indications to surgical treatment should balance between the advantage and disadvantages. The advantage of surgery, it produces satisfactory relief of pain, and it increases the pregnancy rate, and we can obtain tissues to rule out unexpected malignancies. But the disadvantage is that there is the ovarian reserve goes down because of the damage to the ovaries by the cautery or other things. The limitations of surgery for endometrioma in patients who fail to conceive spontaneously after surgery, ART is more effective than repeated surgeries. We should not keep on doing surgeries one after the other because it is a recurring problem. Following surgery, the ovarian reserve may be reduced as determined by anti-Mullerian hormone. In women with large endometriomas, which are measuring more than 5 centimeters, it should be removed. That should be the primary treatment. But the primary treatment should be perfect so that the recurrence does not occur within 3 to 5 years. In women who have failed ART, further management remains controversial. So, what is sclerotherapy? Sclerotherapy was originally used to treat tuberculous pneumonitis and is currently used by medical oncologists to treat the malignant pleural effusion. In India, it's often considered the treatment of choice for small varicose veins, and it is practiced in Delhi. Sclerotherapy involves injecting a solution directly into the vein. The sclerosing solution causes the vein to scar, forcing blood to reroute through healthier veins. The collapsed vein is reabsorbed into local tissue and eventually it fades. So, this is sclerotherapy. So, why sclerotherapy for endometriosis or endometrioma? In the year 2016, April, a patient with severe endometriomas, she had 3 endometriomas, who had already undergone 3 surgeries, and the last surgery was just 3 months ago. She was threatened by her husband and her in-laws to be divorced if she hadn't beget a child within a year. She and her parents were sobbing in my cabin, so the plight of this patient triggered my empathy towards her and made me search the internet for an alternative therapy for endometriosis, which can give a quicker relief and resume fertility at a shorter time. Then I came to know about the entity called sclerotherapy, which was practiced in US, Japan, Taiwan, Canada, and Israel, and some of the European countries, Italy, and so on. And before that, I have never heard of such a thing like sclerotherapy, and it's not mentioned in any of our books also. So, what is the mechanism behind this? The cellular mechanism involved in sclerotherapy of ovarian endometriomas are not fully known, but it seems that epithelial cells lining the cyst wall play an essential role when adequate contact between the sclerosing agent and the cyst wall is achieved. There is activation of coagulation cascade and production of mediators of inflammation causing fibrosis of these epithelial lining cells leading to cyst wall adherence. So further collection of fluid is not possible. Might enhance the cytotoxic activity of macrophages and natural killer cells to suppress the endometrial activity. And this is a novel, cheap OP procedure for treating endometriomas, and in developing and underdeveloped countries where people can't afford much for medical management and repeated surgeries, we tried this newer modality for treating endometriomas. This is the selection criteria, that is women in reproductive age group were selected, and those who are infertile or yet to complete the family, and there should not be any associated fibroids or other causes for infertility. And recurrent endometriosis, those who are suffering from recurrent endometriosis, those who had undergone repeated or recurrent surgeries for endometriomas, and those who belong to stage 3 and stage 4 are the people who have been selected for this therapy. The procedure, under immediate precaution and under antibiotic coverage, which we start from the previous day of aspiration, the endometriomas was sequentially aspirated with a needle of 17 gauge and 35 centimeters long. It is the ovum pickup needle which we used, and we flush with sterile saline until the aspirated fluid was clear. Using the Kraft aspirator, and this procedure was done under ultrasound guidance, an injection of leuprolide 1 milligram and 100 milligram of cephalosporin sulbactam was injected after completing the aspiration. The dose has to be adjusted according to the size of the endometriomas. In case of thick and old endometriomas, aspiration was achieved using 16 gauge and 35 centimeters long needle, that is the double lumen aspiration needle, after injecting normal saline through one tract and diluting the endometriomas through the other tract. The endometriotic fluids have been aspirated. This was conducted as an outpatient procedure, and in very few apprehensive patients we used mild IV sedation or mild anesthesia. In the beginning only we were using anesthesia, but nowadays we don't give them anesthesia. Patients tolerate them very well. These are all some of the endometriomas which we have aspirated. This is the ovum aspiration needle single lumen, and this is ovum aspiration needle with double lumen, and this is the Kraft suction apparatus which we use for doing the aspiration. This is the way how we, under ultrasound guidance, we have to locate the endometriotic cyst, and using the needle guide and through transvaginal approach, we have to enter into the cyst, and then we have to complete the aspiration. But before removing the needle, we have to inject the, after completing the aspiration, we have to inject the sclerosing agent into the cyst wall. If you have 3 cysts, finish one first, and then you have to go to the next one, likewise. So this is an ongoing prospective pilot study that included 82 patients, which was carried out in a hospital from April 2016 till date, and it showed quite impressive results. Out of 82, 38 were infertile patients and 44 were parous women. 29 have already completed their family. The complete resolution was observed in 74 out of 82 patients, giving a 90.2% of complete resolution. And 7 patients didn't show up for follow-up examinations. Repeat treatment with leuprolide was needed in only 6 patients. 1 patient needed surgery after sclerotherapy for persistent recurrence of cyst, and that patient conceived naturally without any treatment, and we have delivered her. And the conception rate was 71.05% through IVF. Not all patients. Out of 38 infertile, 25 patients conceived and delivered through IVF after treating endometriosis with sclerotherapy, and 1 conceived and delivered through IUI, and the other one which after surgery she had a natural conception and she also had delivered. So 20 patients delivered in our hospital and 7 at their mother's place. This is the graphical representation of our results. The success is 90.2% and 71.05% achieved fertility, and restoration of sexual health was appreciated in 80%. Some of the patients, because of pain, have went for divorce, and such patients are completely relieved of pain, and now they are looking for a second marriage. And this is the total number of aspirations was 82, no recurrence in 90.2%, 38 were infertile people, and 27 have achieved fertility. 7 patients didn't turn up for follow-up. The main advantage is that fertility treatment can be resumed in the same month and the very next month after aspiration. That's the very good advantage of this sclerotherapy. Some of the references: this was a study taken from Japan. They used 5% tetracycline as a sclerosing agent. The recurrence rate was 46.87%, and the fertility was achieved in 34.37%. These are the authors. And this was a study from Taiwan where they used 95% ethanol as sclerosing agent. The pregnancy rate was 17.8%, and the regression of cyst was seen in 42.2%. Recurrence was 58%, and these are the authors. So this was another study conducted in Canada and Israel from the Department of Obstetrics and Gynecology McGill in Canada and the Department of Obstetrics and Gynecology in Tel Aviv University, Israel. And they have found out, they advised the dosage of these sclerosing agents. Ethanol, they advised 50 to 100% of initial aspirated cyst volume. Suppose the volume is 25 ml, we have to either give 12.5 or 25 ml of ethanol. And tetracycline, 20 to 100% of initial cyst volume. Methotrexate, they recommend 30 milligram diluted in 3 ml of normal saline as sclerosing agent. And the recurrence rate with ethanol ranges from 0 to 62.5%, and if the ethanol is left in situ, the recurrence is very minimal, that is 0 to 13.3%. And if you do a ethanol wash, if the installation time is less than 6 minutes, then the recurrence is very high, 62.5%. If the installation is more than 10 minutes, the recurrence is very low, 9.1%. With tetracycline, the recurrence rate was 25 to 46%. With methotrexate, it is 18 to 26%. An apparent increase in the antral follicle count was reported after ethanol sclerotherapy, and the overall pregnancy rate after sclerotherapy ranges from 20 to 57%. These are some of the complications seen with the sclerosing agents. With ethanol, you can have abdominal pain and postoperative fever, alcohol intoxication, intracystic abscess, and in 2 studies there were no complications encountered. With the methotrexate, there is postoperative fever and abdominal pain, and in 1 study there was no complication. With tetracycline, abdominal pain, and in 1 study there was no complications. In our sclerosing agent, leuprolide and cefoperazone sulbactam, we have not encountered any complications so far. When I searched the net for the articles that were all published on sclerotherapy for endometriosis, there were around 634 articles so far published on sclerotherapy worldwide. And this is an article that is seen in ASRM. It was a systematic review and meta-analysis conducted by ASRM in 2017, and it says that the sclerotherapy for ovarian endometrioma may be considered in symptomatic women who plan to conceive, and it was published in Fertility Sterility. It was another study conducted in human reproduction and was published in that journal. It was using metronidazole for suppression of endometriotic lesions, but it was done in mice, not in humans. And another one is published in Fertility Sterility. That is, it says that sclerotherapy with 5% tetracycline is a simple, effective alternative to surgical intervention for treatment of endometriomas before IVF. And this is also published by ASRM. I came to know that in Newark Fertility Institute, Dr. Khalid Sultan and Dr. Majid Fateh, they were using sclerotherapy as first-line management for the past 25 years for all the patients who are suffering from endometriomas. And I had a chance to visit them also during my recent visit to States. This is a comparison where the recurrence with tetracycline is 46.87% and the fertility is 34.37%. With ethanol, as I have already told, it is 0 to 13.3%, and the fertility is 20 to 57%. With methotrexate, the recurrence is 18 to 26%, and fertility, no mention of that. And with our sclerosing agent luprolide with cefoperazone sulbactam, the recurrence is 8.3%, and fertility is 71.05%. So these are all some of the, we are comparing our agent with that of ethanol. The mean cyst recurrence rate was 42.2% here, and in ours it's 8.3%. The pain core reduction rate was 71.5% with ethanol, and with luprolide it is 92%. And increased follicular count with ethanol was 36.4%. In ours it's 71%. Repeated aspiration if we use ethanol was around 13.5%. With luprolide it was 8.21%. And surgery after sclerotherapy with ethanol 8.4%. We have done for one patient, that is ours is 1.6%. So these are some of the centers in the world where sclerotherapy is being conducted. In Taiwan, they have done for 274 patients with a pregnancy rate of 17.8%. And in Japan, 5% tetracycline was used in 32 patients with a pregnancy rate of 34.37%. And in Las Vegas, Nevada, USA, for 32 patients, they used 5% tetracycline, and the pregnancy was 50%. In Hiroshima, Yashida, he was doing this sclerotherapy with ethanol. He did for 74 patients, and pregnancy rate was not mentioned, but the recurrence was less than 10. It was no recurrence seen in 62.5%. And this was another study from USA where ethanol was used as a sclerosing agent. Number of aspirations were 18, and no recurrence was between 0 to 62.5%. So this is our statistics where we used luprolide and cefoperazone sulbactam. We have done 82 aspirations, and the patients were followed up to 42 months. The success was 90.2%. The recurrence was 8.3%, and repeat aspiration was done on 6 patients. Infertile people were 38, and fertility achieved was 71.05%, and we have delivered almost all. These are all the each one's that is the age of the patient, the cyst volume, the residual cyst whether present or not, whether they needed a second aspiration or not, what is the ultimate result, and whether they have undergone IVF or IUI, have they become pregnant or not, or have they delivered or not. So the biggest cyst I have aspirated is 580 ml, and we have to do the aspiration twice, and she is still under treatment. So to conclude, endometriosis is an ever challenging disease affecting all age groups from adolescent to perimenopausal women. So individualization of treatment is a must according to the severity of the disease, tolerability of the patient, and the desire for fertility. The standard treatment for symptomatic and endometriomas that were measuring more than 5 centimeters is laparoscopic surgery. Medical therapy is, however, often used before surgery to reduce the size of the lesion and the extent of the operations. Dynages, the wonder molecule, is preferred most for patients' compliance and quicker return of fertility. The advantage of sclerotherapy: it is minimally invasive, cheap, and very cost effective. OP procedure, no need for any admissions, less ovarian manipulation, no low recurrence rate, prevents the drop of AMH, it resumes quicker the fertility, and we can avoid the general anesthesia complications. So this is my first patient for whom I coined this sclerotherapy, and to my great surprise and by the grace of God, she had her natural conception during the lactation amenorrhea, the second conception, and I delivered her in 2018 October. So our results are quite impressive with 90.2% success rate and 71.05% achieved fertility. 80% restoration of sexual health. So, sclerotherapy using newer sclerosing agents prevents repeated surgeries, and it is a boon to the frustrated endometriotic patients. We have not encountered any complications in our study so far. So, to conclude, sclerotherapy using newer sclerosing agent is a new frontier in the management of recurrent endometriomas. You never fail until you stop trying. This is quoted by Albert Einstein. So, thank you so much for your patience listening. I thank the organizers also for giving me this opportunity. Thank you so much.
Thank you, ma'am. Thank you for your updated informations on endometriosis and its treatment, ma'am. It's always a honor hearing you, ma'am. Ma'am, I will read out questions, if any, in the comment
Okay,
box.
okay,
And madam, let me wait for 2 or 3 minutes for the participants to
okay,
post
okay,
their queries, ma'am.
okay. We can wait.
Madam, what about the occurrence of this endometriosis in postmenopausal woman, ma'am? Is there any chances or how it
Uh,
can be treated?
Usually it is estrogen dependent, and because
Okay.
it is post-menopausal women, the estrogen level is very low. So I have not encountered any post-menopausal endometriomas. But if suppose they are on hormone replacement therapy (HRT) and
Okay,
they are prone to get endometriosis, also they were suffering previously. For such patients, it may come, but I have not encountered any case of post-menopausal endometriomas. Of course,
ma'am, whether this hormone therapy will be useful for this endometriosis, ma'am?
yeah, because even after sclerotherapy, we have to continue with either the progestins or dynagers or dynagist. Usually, I continue with dynagist for those who are not opting for fertility. For those who want fertility, I after sclerotherapy we continue with stimulating them, and usually proceed to either IUI or IVF without waiting for the recurrence. So we should not allow them to have a recurrent problem. As soon as we complete the sclerotherapy, the very next month itself we can start stimulating them for those who are infertile. Hello?
Ma'am, yes, ma'am, I can hear you, ma'am.
Yeah,
Thank
yeah.
you, ma'am. Ma'am, any complications associated with this sclerotherapy,
Uh,
like any nerve damage or anything like that?
so far, I have not encountered any complications, but it needs some expertise and training.
Yeah, yeah,
Those
ma'am.
who have done ovum pickup regularly, it will be they will find it very easy. No need for panicking. You can jolly well do with ultrasound guidance because during ovum pickup we do everything under a complete aseptic thing and in a theater. So just like that also we do the sclerotherapy in a perfect sterile manner so that I have not encountered any abscess or any problem so far. Only thing is that we had for 6 patients we have to do a second time, second aspiration, and for one patient I did 3 aspirations with leuprolide. For her, I have tried also metronidazole, which is a newer thing, newer sclerosing thing.
Okay. Ma'am, if there is that is endometriosis with 2 or 3 centimeters, and if there is 2 or 3 endometriomas, then whether it will affect the AMH level, ma'am?
Definitely, endometriosis always damages the ovaries, and the AMH will be very low for these patients. My first patient, her AMH was around 1.3 when she came to me. But after aspirating the endometrioma, the 3 endometriomas that were lodged, the other follicles were started coming up. The other follicles, they were just appearing because the pressure of this follicle was obstructing the other follicles from coming up. So after relieving the pressure, the other follicles will start coming well.
Okay, ma'am.
So, and if the endometriomas are less than 2 centimeters, no need for any aspiration or any sclerotherapy. You can just proceed with stimulating them, and we can avoid puncturing the endometrioma during our ovum pickup. We can just
Yes.
avoid that. No need for any sclerotherapy if the size is less than 2 centimeters.
Okay. Madam, I could not find any other questions in the chat box, ma'am. So if you allow us,
Okay.
then we can end the webinar for the day, ma'am.
Yeah, if they have any questions, they can
Yes,
just
ma'am.
post my.
We'll post you, ma'am.
Yeah, you can
Yes,
send a
ma'am.
mail. I can just clarify their doubts.
Yeah, sure, ma'am. Thank you. Thank you very much for being us with us today, ma'am.
So thank you
And
so much.
on
Thank you so
behalf of
much.
Shield Healthcare, I would like to thank the delegates also for their patient listening. And thank you, one and all.
Thank you so much. Thank you so much.